Good morning friends, welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist we have provided almost all the topics in a very systematic order and this is quite convenient for the study. My dear friends, you have been discussing about the bleeding and clotting disorders in children. In that aspect we have already covered 4 or 5 parts. Now today we will cover approach to a patient of bleeding disorder and how we have to proceed. Now whenever we get a child with the bleeding, then we have to think about the following possibilities. Number one is there is a bleeding, therefore it may be a platelet disorder, which is the most commonest one. It may be a coagulation disorder. It may be von Willebrand's disease or it may be vasculitis. So these are the things that should come to our mind. Maybe a coagulation disorder. Bleeding is taking place. It may be internal bleeding or it may be external bleeding, but bleeding is going on. So it may be a platelet disorder, it may be a coagulation disorder, it may be a von Willebrand's disease or it may be a simple vasculitis, which is quite common in so many autoimmune disorders. Now by looking at the site of the bleeding, if the bleeding is going on in the joints, suppose the bleeding is taking place in the joints, the most pressure point areas, then most probably this is not a platelet problem, rather this will be a coagulation disorder. If the bleeding is going on in the skin, mucous membrane, gums, epistaxis or GAT, then we have to suspect the platelet problems or some of the vascular abnormalities, maybe vasculitis. Therefore, in case of clotting disorders, always we have to look into the pressure point areas like the knee joint, maybe elbow joint, shoulder joint or hip joint, etc., where so there will be collection of the blood in the form of the hemoarthrosis, hematoma, etc. Now next thing what we have to do is we have to look into the type of the bleeding. So if the type of the bleeding is hemoarthrosis, that is collection of the blood in the space, maybe in the joint space, so most probably it will be a coagulation disorder, because if it is a platelet problem, the presentation will be either in the skin or the mucous membrane, not in the deep areas of the body. If the type is petechial and purpura, definitely it is in the skin, therefore it is platelet or vascular abnormality. And if there is a history of surgery or trauma, if there is a history of surgery and trauma and now there is bleeding going on, then you have to think about the coagulation disorders. Because at the time of the surgery, so they will stitch, everything will be fine, but there is undetected coagulation problem which bleeds from the site in the later parts. And if there is a spontaneous bleeding from the skin and mucous membrane, okay, spontaneously there is bleeding, there is no any history of trauma, surgery, etc., spontaneously it is bleeding, so probably this will be a platelet problem or maybe vascular disorders. Now another approach is about the drug history. You have to take the drug history, very important in case of coagulation and bleeding problems, because many of the drugs will go into affect the hemostasis. Hemostasis affecting drugs are there. For example, aspirin, clopidogrel, anticonvulsant drugs like valproic acid, carbamazepine, etc. So they are known to disrupt the hemostatic mechanism. So if the patient is taking these drugs for a long time, definitely there may be the chance of bleeding from the different parts of the body. We have to also ask about the family history. Now in the bleeding and clotting disorder, family history is very important. A similar type of incidence is present in the family members also. Then we have to think about the hereditary disorders, especially related to the clotting, so that is hemophilia group of disorders. So in all such conditions, when once we have got the approach, now we have to go for the screening test. So first we will go for the screening test. What are the different screening tests which is involved? From the platelet point of view, the different in order to diagnose the platelet disorders at the earliest, platelet counts, bleeding time, platelet function analyzer, platelet aggregation, and PBS, peripheral blood smear. So this is to identify different platelet problems. Whereas, as far as the clotting problems are considered, prothrombin time, activated partial thromboplastin time, that is APTP, then thrombin time, mixing studies, clotting factor assays, and Bexersa test. This is to find out the inhibitors. There are some inhibitors are there. So we have to go for Bexersa test. So starting with the screening test for the platelet problems, normal platelet count, everybody knows, normal platelet count concentration is about 1.5 to 4.5 lakhs mm³. The platelet count less than 1.5 lakhs is considered as thrombocytopenia. If the platelet count falls below 1.5, then usually we will call it as thrombocytopenia. Now, thrombocytopenia is the most common acquired cause of bleeding diathesis in children. Thrombocytopenia is the most common acquired cause of bleeding. So, this bleeding problems in children is most commonly because of thrombocytopenia. This thrombocytopenia may occur because of various causes. So anyway, one is platelet count. Second one is bleeding time. Normal bleeding time is about 4 to 8 minutes. This assesses the function of the platelets and their interaction with the vascular wall. How it causes the bleeding will be stopped, that we know. So how the bleeding will going to stop, that we know. So within 4 to 8 minutes, the bleeding will going to stop. And if it is normal, then it indicates the proper interaction with the vascular wall. Platelet count which is less than 1 lakh will be associated with the prolonged bleeding time, while disproportionate prolongation of the bleeding time may suggest a qualitative platelet defect or von Willebrand disease. What do you mean by disproportionate prolongation of the bleeding time? That is, platelet count is normal, but still bleeding time is increased. So this is disproportionate. That means structurally, count-wise, the platelet is okay. There is some problem with the quality. Function of the platelet is get affected. So therefore, BT is affected or prolonged. Another important screening test is PFA 100, that is platelet function analyzer. It measures the platelet adhesion, aggregation in the whole blood when exposed to either collagen epinephrine or collagen ADP. It evaluates the early stage of hemostasis, the platelet function and von Willebrand factor interaction, so that it will going to help. Platelet function analyzer helps the early function of the early stage of the hemostasis, adhesion and all, where von Willebrand factor is produced, and it will interact with the endothelial wall, and then the aggregation starts. So whenever there is endothelial injury, platelets will adhere to the endothelium by the help of a factor called as von Willebrand factor we have discussed, and then there will be platelet aggregation. So what is the help of PFA 100 is extremely sensitive to presence of aspirin and may be used to monitor the antiplatelet drug therapy. Now another test is platelet aggregation. This is to detect the qualitative platelet function test. Platelet-rich plasma of the patient is activated with one of a series of agonists like ADP, epinephrine, collagen, thrombin or thrombin receptor, peptides and risotocin. So now come to the screening test related to the clotting factors. The first one is prothrombin time. Prothrombin time measures the activation of the clotting factors by the tissue factor, already we discussed, tissue factor mediated, and it explains the extrinsic and common pathway. So prothrombin time is the indicator of a extrinsic pathway and also the common pathway after factor number 10. The normal prothrombin value is about 10 to 13 seconds. The prothrombin is not prolonged with the deficiency of the factor 8, 9 and 12. The reason is very simple. 8, 9, 12 they comes under the intrinsic pathway. Okay, so prothrombin time from factor number 10 it starts. So prothrombin time is an indicator of extrinsic pathway. Now another one is PT-PT or APTT, activated partial thromboplastin time. So this measures the activation of the clotting factor. This measures the activation of the clotting factors by intrinsic pathway and also the common pathway. That one is for extrinsic pathway and common pathway. This uses a contact activator like silica, choline or ellagic acid in the presence of calcium or phospholipids. Now deficiency of the contact factors. Prothrombin time can be also prolonged without symptoms by the deficiency of the factor number 12. Pre-kallikrein and HMW kinogen at this deficiency are asymptomatic. Talking about the thrombin time measures the final step clotting cascade in which fibrinogen is converted into fibrin. So if the thrombin time is get affected, that suggests that there is fibrinogen conversion into fibrin is get affected. The normal thrombin time is 11 to 15 seconds. Now prolonged TT, prolonged thrombin time, in reduced fibrinogen or dysfunctional fibrinogen, it is seen, as I told, either the fibrinogen is reduced or it is dysfunctional, or in the presence of the substance which interferes with the fibrin, which blocks the further action of the fibrin. So polymerization such as, for example, the materials like as heparin and fibrin split products, so they will interfere with the fibrinogen formation, fibrinogen conversion. Another one is reptilase time, RT. It is called as RT, reptilase time. So the reptilase is the one which uses a snake venom to clot the fibrinogen. So unlike the thrombin time, this is not very sensitive to heparin. So RT is prolonged only by reduced or dysfunctional fibrinogen or fibrin split products. Another screening test is mixing studies. If there is unexplained prolongation of the PT, APTT, TT, then we will go for mixing studies done. Unexplained, we are not able to identify any problem in the extrinsic pathway or mixed pathway or common pathway or in the intrinsic pathway, but still they are raised. Now we will go for the mixing studies. What we will do here? The normal plasma is added to the patient's plasma. Patient plasma is now showing high amount of the prothrombin, thrombin time, etc. The normal plasma is added. Okay. And again, after adding the normal plasma to the patient's plasma, the test is again repeated. If there is correction of the PT and PTTT, now previously PT and TT etc. raised. Now after adding the normal plasma, if it is get corrected, it suggests that there is deficiency of some of the clotting factor which is left unidentified. Because after adding normal plasma, that clotting factor has been provided and the finding is normal. So that suggests that previously there is some deficiencies which is left unnoticed. But if it is not corrected, or only partially corrected, means there is presence of some of the inhibitor. There is no deficiency of any particular clotting factor. Rather, there will be some inhibitors are present. Therefore, even after adding the normal plasma also, it is not get corrected. So therefore, the last test will go, that's called as Bexeda test. So this quantify the amount of the inhibitors present in the plasma, especially for the inhibitors like factor number 8 and factor number 9. Okay, so this is the normal screening test which we conduct for the bleeding disorders, especially for the platelet and clotting factor disorders. Rest of the things we will continue in the next class. Thank you very much.